Hello, welcome to this Becker's webinar hosted by AdaptX and the Joint Commission. And we're here to talk about a really important topic about how to elevate sustainability practices in healthcare. My name is Dr. Dan Lowe. I'm the Chief Medical Officer at AdaptX. I'm also a practicing pediatric anesthesiologist at Seattle Children's. I'm joined by my two guests today. I've got Dr. Liz Hansen, is a pediatric anesthesiologist at Seattle Children's. She also holds the rank of assistant professor in the Department of Anesthesiology at the University of Washington. And she is the founder of Project Spruce. And we'll be hearing more about that during the webinar. And over on the far side, we have Chad Larson. Chad is an executive director with the Joint Commission and is responsible for the hospital accreditation program and some of the certifications you'll be hearing about during the presentation too. So very warm welcome to you, Liz and Chad. Thank you for joining us today. And let me kick off with why we're here, and then I'll kind of turn it over to you guys. So we're here to talk about sustainability and healthcare's role in becoming more sustainable or, causing less planetary harm. And it's come to light in more recent times that US healthcare or global healthcare is a huge source of carbon emissions or greenhouse gas emissions. Global healthcare, if it was a country, would be the fifth largest country on the planet as far as greenhouse gas emissions. If you just take the US healthcare sector, the best estimates are somewhere between 8.5% and 10% of carbon emissions for the country are due to US healthcare. And that obviously has huge impacts on people's health. And that's why we're here to talk about, well, what is our responsibility here? So I want to start at a pretty high level. We'll start with maybe Chad. From the Joint Commission's perspective as one of the largest regulator of healthcare systems, can you give us a couple of minutes on why this has become a priority for the Joint Commission?
Yeah, thanks, Dan, and I appreciate the opportunity here today. And I think you've really done a great job of kind of framing up what the problem here is, and that the healthcare sector really does contribute disproportionately to climate change. It's sort of an unintended consequence in healthcare of really trying to do good for all people. And the Joint Commission, the purpose of the Joint Commission and accreditation and certification programs is really to enhance quality of care and patient safety. It's really at the root of the Joint Commission's mission and vision. And climate change and air quality are healthcare equity, and really ultimately patient safety issues. People often impacted the hardest by climate events are often burdened with adverse social determinants of health. Reducing greenhouse gas emissions is an imperative for improving healthcare equity and patient safety. And the Joint Commission has been committed to resolving health disparities through new core healthcare equity accreditation requirements, because really addressing social determinants of health is also a patient safety and quality of care need too. Really with that, our work in sustainability was, part of it was a call of action from healthcare organizations who really wanted to see the Joint Commission get more involved in sustainability initiatives, and really looking to the Joint Commission as a nationally recognized leader in standards development. There were several organizations who reached out to us to develop a program that was really intended to strengthen and accelerate their own sustainability practices. And we know our environment plays in impact every day on our health. Air quality improvements can create healthier environments that promote healing and can lead to better health outcomes. And hopefully minimizing those negative impacts on our environment will ultimately benefit the health and well-being of patients. So sustainable healthcare practices, will lead to those improved patient outcomes and hopefully overall health outcomes for the communities and for patients that our healthcare organizations serve.
Great, thank you. Liz, I want to turn the question to you. Can you, same question, so, but from a hospital system point of view and then also a personal point of view. So why has Seattle Children's, the hospital that you're working at, why what is their response to this call to action? And also on a more personal note, can you give us a little bit about what makes you tick? How did you get into this? And what is your motivation and kind of true north here?
Yeah, thanks, Dan, for that question. It is really personal to me. 5 or 6 years ago, I was reading the reports coming out about the climate crisis and planetary health, learning more about healthcare delivery contributing to that harm, and feeling really demoralized and stuck and thinking, okay, I'm riding my bike to work. I'm, promoting plant-forward meals in my family. I have to do something more. And I met with Colleen Grohl, who was our sustainability manager at Seattle Children's Hospital. She showed me some of the work that she'd been doing, inventorying our greenhouse gas emissions for the hospital using practice green health tools, some really nice tools out there to keep track of the emissions that the hospital is responsible for. At the same time, some colleagues at the hospital, specifically Dr. Marcus Booz, one of the dermatologists, was working really tirelessly to get the attention of our leadership and the C-suite to address this issue and really bringing light to this and saying, we care about this as clinicians, as hospital workers, as advocates for our patients. This is important to us. And the hospital really listened to him and responded and made some really aggressive pledges and goals. So one of them is Seattle Children's Hospital will deliver carbon neutral care by 2025. And so part of that is keeping track of what we're emitting to figure out how we're going to get there. So Colleen showed me some really interesting data that she had collected from our purchasing department looking at the anesthesia gases. So I'm a pediatric anesthesiologist. I use these gases every day. And she was showing me they were responsible for 7% of our hospital's carbon emissions. So Dan, I don't know if you want to pull up that slide. It was kind of shocking for me to see that, within the whole hospital emissions, we're seeing things like, natural gas for our steam boilers and our kitchens and things like that. And then our commuting, obviously, we knew that was a big issue, promoting lots of carpooling and cycling into work and things like that. But the anesthesia gases was the third largest source of direct emissions, those scope 1 emissions from our hospital, and really the only clinical area on that pie chart.
Okay, great. I won't pull up the slide right now, but I'm going to
Oh, sorry.
for a couple of minutes later. But thank you for that overview and intro into kind of the hospital perspective and your personal story. Thank you for sharing that. So let's just back up again and let's, Chad, I want to get your perspective. Can you tell the audience a little bit more about what the Joint Commission, their commitment to sustainability, and a little bit about the certification, the new sustainability certification you guys are starting out?
Yeah, absolutely, Dan. So as we advance to the next slide, we'll talk a little bit about our new sustainability certification program. This is, again, a response. We're listening to our accredited hospitals and healthcare organizations that are admirably leading the way in this space. And so a reflection of their progress in this space was really to create a voluntary certification program that aims to help accelerate sustainability practices and reduce greenhouse gas emissions. So our Sustainable Healthcare Certification Program is a new voluntary certification program. It launched to all hospitals and health systems on January 1st. The program is really designed to evaluate and recognize hospitals who have made reducing their carbon footprint a strategic priority within their organization. So really where I see the value to this is, the program's really kind of providing that framework that organizations can follow to help leadership set priorities, to help develop practices to reduce waste and greenhouse gas emissions. We recognize that certification may be a long-term goal, could be a very long process and journey for organizations, but the certification program and the framework's really kind of creating some guide rails, and we're also creating some resources and providing resources for organizations that are really intended to support their goals and journey to reduce greenhouse gas emissions. One unique trait to this program is we actually have a resource center. And it's really providing a roadmap for short and long-term strategies that organizations can help follow to advance their own sustainability practices. So this is a resource center, really, and thank you to Liz's organization, Seattle Children's, who contributed to this resource center to help organizations learn from one another. It's this resource center, the review process is really designed to foster kind of this learning collaborative where organizations can learn from one another through leading practices and strategies. So while the certification is awarded to organizations for a 2-year period, organizations can also choose to apply as either a single hospital site or at a system level. So this is where a larger corporate initiative might be going on, or where there's more of an integrated or centralized approach to reducing greenhouse gas emissions. So the system process is newer. It's a newer approach to how Joint Commission has traditionally taken its approach to accreditation and certification, where we actually give organizations the recognition at the health system level, where there's more of that integrated approach. We know there's many different energy intensive activities within hospitals and health systems today. The Joint Commission is focusing their sources of greenhouse gas emissions in these 6 areas for purposes of the certification program. So we're actually asking organizations to track, measure at minimum 3 of the 6 emission sources listed here. So energy use as a result of fuel combustion, purchase electricity, including purchase grid electricity, purchase district steam or district heat, measurement of anesthetic gases, including volatile agents and nitrous oxide, which you'll be hearing from Liz more about, pressurized meter dose inhaler usage, fleet vehicle, carbon-based fuel use, and finally waste disposal. So this includes waste that's generated within hospital operations, could be plastics from gloves, catheter bags, empty bottles, food waste. So we're tracking these, which are primarily the I would say the primary sources of greenhouse gas emissions.
Mm-hmm.
As we move to the next slide, I'll cover just a couple areas of the standards. These are the domains, or really the kind of the makeup of the program requirements that make up our sustainable certification. These are developed and informed by literature, guidance documents. We also had a 22-member technical advisory panel made up of individuals within healthcare organizations that helped to develop these standards. And so that first domain is really looking at the leadership chapter, which is establishing environmental sustainability as one of the organization's strategic priorities. The measurement domain is really looking to see that the organization's measuring at minimum 3 sources of greenhouse gas emissions. We actually ask organizations to convert their activity data into metric tons of carbon dioxide equivalent. And we actually do this because metric tons of carbon dioxide equivalent is the standard unit comparison to really kind of look at through the different types of greenhouse gas emissions. And then the third domain to this is the performance improvement chapter. So really here what we're looking at is what is in the organization's written goals and action plan, and what are they doing to support the reduction of greenhouse gases. So, and here we're really stressing the importance of data collection, of the analysis of the data, tracking progress towards your goals. What are you doing when goals are not being met or sustained over time? So how are you taking action on that? But then also how you're informing your leadership within your organization. And we ask that in this case that leadership's being informed at least annually on progress towards your goals. And that's really the overview of the standards at a very, very high level. The review process on the next slide really kind of covers really the how. How are we going about evaluating organizations? So, in a traditional manner, if you're familiar with Joint Commission accreditation and certification, we conduct our surveys and reviews on site. And in doing this, we actually looked at doing an assessment of these standards and the requirements and what we're asking of organizations. And a unique aspect to this is we recognized an opportunity here to minimize travel and hopping on an airplane and sending surveyors out to conduct this event. And we're actually conducting this review in a virtual manner. We don't ask for a requirement for uploads of any documents or sharing of documents prior to the review, but we really found a lot of this review process could be completely done in a virtual format, similar to a Zoom environment. The review itself is conducted by our life safety code engineers. These are a special subset, a surveyor cadre, employed professionals of the Joint Commission with professional previous experience leading their own sustainability initiatives in healthcare organizations. Another aspect to this is organizations going through the review for the first time receive a 30-day advance notification of the review event. And we always give a more shortened advance notice, a 7-day advance notice of recertification reviews. But this is really an opportunity for organizations to share in their processes and share more about the coordination of their greenhouse gas reduction activities. And it gives the organization, it gives the Joint Commission insights into your strategic planning process, how your resources are allocated for decarbonization activity, and overall just giving us the ability to look at your approach to performance improvement and your data collection capabilities too. We talked a little bit about in the opening, but this is kind of a key piece to this is that organizations have the ability to be recognized as a health system for sustainable healthcare certification, which is a new and kind of unique characteristic that we've not done with traditional certifications before. So where there's more of the centralized approach or an integrated approach at the corporate level in sustainability efforts, there's an opportunity to be recognized for that. Just sharing very quickly here, our resource center, I dropped a link in here, but this is really where you can learn strategies, tools, tips on how you can find actionable strategies to help guide your own organization in your environmental journey, learning from other organizations, key resources to help you along your own journey. And the QR code in here, if you have any more questions or you want more information about the Sustainable Healthcare Certification Program, you can take a snapshot of that QR code and it'll take you to the website for more information. And I'll turn it back to you, Dan.
Thank you so much. Well, I appreciate everything that you and the Joint Commission are doing on this. You've given us the industry, a really clear framework, I think is the best word to describe it. And that framework of, leadership combined with measurement, combined with performance improvement. And it's interesting that pretty much the only big clinical area called out is anesthetic gases. And that's a great segue to Liz. So Liz, can you share with us some of your work? How did you combine those leadership, performance improvement, measurement, and with management and reduction of anesthesia gases? And why is that an important problem?
Yeah, so I mean, the operating room is a source of a massive amount of waste, emissions, utilization of resources, and this is where I work every day. So you see it, when you're in the operating room, you see the big bins filling up with plastic, single-use plastic. You see all the lights and equipment that are on using energy, active warming, all of that. And then what you don't really see is the anesthesia gases, but that's a huge source of emissions. As I mentioned, for our hospital, 7% of our total hospital emissions, it can be up to 40% of scope 1 emissions coming from these anesthetic gases. And these are gases that, we use every day to take care of our patients. They're necessary in a lot of ways, but there are a lot of really evidence-based methods to reduce the impact while still providing excellent patient care. So when I started learning about this, from Colleen and then reading the papers from Jody Sherman and others who've, really pioneered this work, seeing, those evidence-based strategies laid out, I realized, we're not really doing those. And so we needed a way to implement those strategies. And then, Dan, exactly as you said, measure and track. So the good news is there's tools out there, and there are these evidence-based recommendations. These inhaled anesthetics are greenhouse gases, and some of them are worse than others. So desflurane is one of the ones that's really bad. It has a very high global warming potential, meaning it is better at warming the planet than the others. So a single bottle of desflurane is equivalent, if it's used vaporized, to burning almost 1,000 pounds of coal. So this is really dramatic. And that's, I mean, this is the scale that we're talking about.
Give the audience a little bit more context with this. So there's a 240 ml bottle of desflurane. So if someone ran this at wasteful flows, how quickly could you go through that?
Yeah, I mean, it depends. If you're using it for all your cases, this is, less than a week. But I think, depending on how you do it, that's kind of what we needed to understand is if you're doing low flows, if you're choosing alternatives, then it's spread out a lot more and we can be more efficient while still delivering the same patient experience or even a better patient experience that's safer and less harmful to the environment.
We're talking about less waste, not less delivery of drug, but less waste use.
Right, and that's part of that evidence-based practice recommendation is the low flow anesthesia. And so this is a little technical, but we have this method of delivering anesthesia gases using an anesthesia machine with a circle system where we're delivering this inhaled anesthetic into the patient's airway with a breathing tube, for example, or a mask. And we provide fresh gas flow in to kind of drive that and deliver new oxygen molecules as we go through. And then we have absorbents to take the carbon dioxide that the patient's breathing out away. These are not really, the agents that we use are not really metabolized in a significant way by the patient, maybe only 5% metabolism. So when we have high fresh gas flows bringing new oxygen and air into the system, we're kind of driving through these volatile inhaled anesthetics and venting them out the roof of the hospital without using them again, which we could do if we lowered our fresh gas flows and we were more efficient with our use, still delivering the same concentration to our patients, but being more efficient about it and less wasteful. So thank you. Now I have my slide from the pie chart here of our greenhouse gas inventory that Colleen put together. And, our sustainability team, now led by Srini Pendikatla, is doing this every year, making an inventory of our greenhouse gas emissions for the entire hospital. And again, the natural gas, that's a big part of it. And the sustainability team is working really hard to convert a lot of this over and decarbonize, use electric boiler, options instead. The commuting tools that we have to promote, carpooling, walking, biking, taking public transit. Those are all really strong initiatives. And then we have the anesthesia gases as 7%. So this is a huge amount, 7% of 22,000 metric tons. This was, really a shocking number for me to see. And it's because we were not really using these evidence-based practices to have low flow anesthesia to avoid the high impact agents like desflurane that we mentioned.
Great. Well, tell us a little bit more. So how did you go about reducing that slice of the pie chart to almost nothing, not quite nothing, but almost.
Yeah. So, I mean, it took a few years because really what we needed to do was educate our department about this. And I needed to educate myself. So this was something that we didn't really have a lot of knowledge of prior to starting to really socialize and educate on this after we learned about the issue. So I started reading the papers, bringing this information to the group, talking about the alternatives that we could, avoid desflurane, avoid nitrous oxide. We could use low flow anesthesia. We could use IV anesthesia alternatives like propofol-based anesthetics. And so we started to incorporate that into our educational programs with our residents and our fellows and within our department, giving morning talks. And then even just, talking about it in the break room over lunch with our peers and saying, oh, I tried, a nitrous-free induction for my patient. So we usually would use nitrous oxide with our inhalation inductions for our pediatric patients. So when we put the mask on to have our patients go to sleep, we would use nitrous oxide for almost every patient. And then we started practicing without it and, realizing that it was totally doable. It was still a good experience and we could get good at it. So just sharing those kinds of tips with each other was really important as part of that socialization and education phase. And then we began to talk about desflurane more seriously. So we were talking about how it was one of the worst ones. It has the worst one. The global warming potential of desflurane is 2,540 times that of carbon dioxide. So very, very high global warming potential. we have alternatives. We don't need to use it. So we decided as a group, let's put the vaporizers in the workroom. And if you need it because you think it's the only way to safely take care of your patient, you can get it. But otherwise, we're going to stop using it. And so we did that for a while. And then we decided, okay, we don't actually ever need it. The whole group basically was okay without it. And so we were able to remove it from our formulary. So that was one big step. We added some tools and practice constraints to help people use that low flow anesthesia. So the way that our machines worked, the default when you turn on the machine for our fresh gas flow, remember that's how we deliver the anesthesia, was 8 liters per minute, which was pretty high and way more than was needed for the vast majority of our pediatric patients. So we changed that default. So when the machine turns on, it's 3 liters a minute. And of course, clinicians can change it and adjust it as they need it. We're not taking away that ability for our clinicians to do what they think is right for the patient, but it just changed the default and the starting point. And 3 liters a minute is perfectly adequate for most of our patients. So that worked really well to just reduce the amount of the anesthesia gases that were wasted and not even, really needed for the patient. And then we launched Project Spruce. So Project Spruce is kind of the whole thing for this. So it's the socialization education, those practice constraints, and then the big part was the data feedback. And that happened because I was sitting next to Dan one day at work and telling him, we have the math to convert the information we have in the electronic medical record with our fresh gas flows and our percentage of inhaled agents that we're using. And we can convert that to that basic metric that Chad was talking about, the carbon dioxide equivalence. So he was talking about metric tons, but in the individual anesthesia case, we can talk about kilograms and kilograms per minute or per hour. So there's ways to convert these into that universal unit of kilograms of CO2 equivalents. And so I'm telling Dan this, and I told him I'm working with one of the data analysts to try to, get this in a table so I can, look at this and see which cases have high emissions and which cases have low emissions so we can learn and improve. And Dan said, well, why don't we just put this in our software that we, his software that he developed, AdaptX. And so that's how that happened. And Dan was able to get this data into the AdaptX feed. And Dan, do you want to talk about AdaptX?
Yeah. Well, let's talk about this for a sec. That's a good segue. So just to orientate the audience, Seattle Children's gives about 20,000 anesthetics a year to patients across all our sites. You're looking at data from 2017 until yesterday here. And so there's probably over 120,000 patients represented in this chart. And what we're looking at here is as this is what Chad was saying, you've got to be able to measure this in common units. So we convert those data that's captured automatically by our modern electronic medical records. It's all captured there. And we do the math behind the scenes, and you convert it to, well, how many kilograms of CO2 equivalent did you produce per minute per case? And this is remarkable. Liz, I mean, we're looking at from almost 0.26 to 0.02. That's more than a 10-fold reduction here of what we're looking at. And that is so that's showing the system. I think what the next slide we should talk about is keep on looking at this chart, but now look at it like this. This is the same data. And Liz, maybe you want to take over here and tell us about how we think about this.
Right. So this is the way of displaying the data that was really useful for individual clinicians to monitor their progress. So this is the same data as the previous slide, but now we've pivoted the data by anesthesiologist. And we can do this by nurse anesthetists, by resident, by fellow. So everyone can see where they are in their emissions compared to their peers and how they're progressing over time. So each one of these dots is one of us, one of the anesthesiologists at Seattle Children's, and I can see my own data on here. But we could see the way that people responded to the different interventions by doing this. So you can see at the beginning when we had our highest emissions, so our baseline data, we had a really big spread. We had a heterogeneous, data system here. So this is, we have really high emitters like anesthesiologist A, and then we have some low emitters down at the bottom that are already probably avoiding desflurane and nitrous oxide. And so anesthesiologist A is somebody who was using those high impact agents and had really no education about this. And so it wasn't on their mind to think about this. But when we started our socialization phase, they had a massive decrease. So 50% reduction, more than 50% reduction off the bat, just from knowing about the problem and talking about it. So we have this big decrease there, and then the practice constraints start to come in. Desflurane use drops dramatically, and now in the practice constraint session they're totally average. They're indistinguishable from the rest of the group, and that's where they stay. So now they've moved along with the rest of the group into our decreased emissions state, now where we are now. Anesthesiologist B was somebody who, used nitrous oxide routinely, did not ever really turn their fresh gas flows down, so kept those fresh gas flows pretty high, responded very little to the socialization, maybe was using a little bit lower flows or a little bit less nitrous oxide, but then is a clear outlier in our practice constraint and even our data feedback phase. Had a reduction from where they were before, but remain an outlier because it wasn't a priority for that person. And so even, even with the practice constraints, we got a 50% reduction, but we still weren't able to bring them down to the rest of the group. And then you can see in this data feedback, the purple section here, we have a couple of other outliers. And again, those are people who, just still really wanted to use their nitrous oxide and had a hard time figuring out how to do it without, just wasn't a priority for them. And then in our current state, our new low, we had another instance of special cause variation here. Anesthesiologist B retired from clinical practice, and the remaining outliers from the previous grouping, they got in line. They figured it out. They finally, were able to let go of their nitrous oxide and have very low emissions now as well. And then anesthesiologist C is someone I thought would be really low because they're somebody who taught all the residents how to use IV anesthesia. So, we know that propofol-based anesthetics have vastly lower emissions than the volatile and inhaled anesthetic options. There are issues with disposal. We have to be mindful of wastewater contamination and things like that with propofol, but we know that the emissions are orders of magnitude lower. So this is somebody who was using propofol, and I thought, surely they're going to be one of the low emitters. But what we realized was that they were still inducing anesthesia with the mask, using nitrous oxide and using high flows. And so it was just not really understood that those first few minutes of the case with the mask induction in pediatric anesthesia before the IV is in and they could switch over to the propofol, that was emitting a lot of CO2 equivalents. So once they understood that, changed their practice, avoided nitrous oxide, lowered down the flows, then they became one of our very lowest emitters because of that use of propofol. So that was a story where what the perception, I thought this was going to be one of the low emitters, but what we realized was that we have to really look at the entire case and all of the choices that we're making from induction to maintenance to emergence, and the choices of fresh gas flow and which agents you're using impact that at various stages.
Yeah. And Chad, when the Joint Commission thinks about and talks about performance improvement, is this what you have in mind, where a system is measuring itself, it does an intervention, it sees does it improve, it does another intervention, does it improve, it does another intervention, does it improve? But I think we take it one more step, because we understand, especially is a system is made up of people. So you have to get people the individual feedback. Dr. A has to know that. If Dr. A just knows what the system's doing, there's no ownership there. So being able to give that, and as I said, this data is current as of yesterday. So you can see, how did I do yesterday? It's like, to me, I feel like it's like riding Peloton, right? Nobody rides Peloton if you don't give them the score at the end of the ride. So you have to get that circle, that circle, that flywheel effect. Okay, so this is amazing, Liz. And for the audience listening in, this is a tenfold difference. If you pick up any medical journal, but the New England Journal of Medicine or the BMJ or any of the highest, or the Lancet, pick up any journal and look, is there anything that anybody has moved by 10% ever? And the answer is vanishingly rare. The needle never moves more than 10% in anything in medicine. This is not 10%. This is 10x. So the order of magnitude of what you've done here, Liz, is just extraordinary. And I just very proud to call you one of my colleagues and very proud of what you've done. And it's like you've taken us way further than I ever imagined that we could go. Now, tell us, how is this spreading beyond Seattle Children's?
Well, I have to first give credit to our group, Dan. I mean, this was an effort by everyone in our entire division in pediatric anesthesiology to take this on and change their practice and maintain really excellent care of our patients. So I just want to give them credit where it's due. This was, really, really great work by our whole group. We got a chance to present this data at a conference, talk to some people about what we were doing, and connected with people like Diane Gordon, who is another pediatric anesthesiologist at Colorado Children's Hospital, Children's Hospital, Colorado, who is the leader of the special interest group of sustainability for the Society for Pediatric Anesthesiology. So connecting with her and the membership of that organization, that special interest group, there was a lot of interest in this kind of work. And people said, oh, I've been trying to do this. I have a sticker on our vaporizers that says, turn down the flows or don't use desflurane. And people had been coming up with really creative ways of getting the message out to their teams, but they didn't necessarily have a good way to measure and give that feedback. And they were looking for help to incorporate some of these kinds of things together and learn from each other so that we could all do this same kind of thing together. So with support from SPA leadership, Myron Yaster, Lynn Martin, our mentor for this project, we formed a consortium called Project Spruce. And we are now, almost a dozen children's hospitals who are working together to implement these same evidence-based strategies with socialization, practice constraints, and data feedback. We meet monthly. We talk about how we're all doing. And we're seeing amazing progress in places where, this is harder than in the Pacific Northwest, where everyone in the department is, already an environmentalist. In places like Akron, Ohio, our collaborator there, she is making amazing progress getting her emissions down in her group with really creative strategies and giving this data feedback to the group. So people really have to confront, okay, I am responsible for this amount of emissions when I take care of my patients, and my colleagues are showing me that there's another way to do this that's better for the environment. They still take great care of their patients. We can check all of these balancing measures. I need to get with the program and do this too. So that sense of, competition, of, wanting to do the right thing for your patients and for your group. It's really amazing to see that this is able to happen in all of these different diverse practice settings. So we're super proud of our collaborators. Yeah.
So the work started at Seattle Children's. This is the 10x reduction that we talked about. We'll dive into a bit more detail in the consortium in a second. What message do you have for other hospitals who are trying to persuade their leadership? That's one of Chad's 3 pillars. You need the leadership as well as the measurement and the performance. You have frontline clinicians or maybe, mid-level kind of like management. They want to do this. How do they persuade their C-suite that this is a worthwhile thing to do?
Yeah, I mean, it's obviously the right thing to do, right? We can take great care of our patients while reducing our impact, but we can also save money, which is great. Everyone wants to save money. So because we're lowering our fresh gas flows, we're more efficient with our anesthesia delivery. Again, patient is still getting the same amount of anesthesia that they need, but we're being more efficient, we're wasting less, so we're saving a lot of money. And that's, I think, a big win for the C-suite to hear about. We're emitting less. So when we have these goals, when our hospital says, okay, we're going to cut our emissions, this is a really important way to start achieving those goals. Our entire hospital greenhouse gas emissions, 7% was coming from anesthesia gases, right? So if we can reduce that by tenfold, we're going to get that down to less than 1%. But there is a caveat here. So Dan, if you want to go back to the slide
that one
before we talk about money again, there's an issue here. So what we were seeing, and this was really facilitated by having the access to the data. So you'll recall that Colleen was using practice green health tools to measure to inventory our greenhouse gases using purchasing data. So we had that data annually. But then what having the data in AdaptX allowed us to do was say, okay, we have this much that we purchased, but then we used this much for our patients. And we found a really big gap. So we see that we purchased a lot more nitrous oxide than we used. We were able to, that's in the blue there. And then purple was desflurane, which we, stopped using, removed from formulary. So that line is gone. Isoflurane has always been a pretty small contributor. We're not using it in many of our cases. And then sevoflurane, we're using less of it because we're more efficient here in yellow. And so we've gotten this really big reduction with our measured emissions, but we do have a reduction in our purchased emissions too, but it's still, there's a big gap here. And so the reason for that is not necessarily it's being used by outside of the operating room groups like the dental clinic, the ER, mobile sedation team. They're using some too, but it's not that much. The issue here is that our central supply of nitrous oxide that delivers from cryo tanks in the central supply area through pipes through the hospital has some leaks associated with it and inefficiencies in the system. And that can be leaks in the pipe fittings themselves, the manifolds and the valves and all of that. It's very hard to make a system completely gas tight, but our facilities and engineering folks do a great job. They check it, they fix those issues when they come up. The biggest problem is actually the cryo tanks. They have a pressure release valve that releases pressure, which means venting nitrous oxide out of the cryo tank so that pressure doesn't build up in the tank. And that's a feature of those tanks. So even in the most perfectly designed system here, those tanks will end up emptying themselves over time, even without any clinical use.
Wow.
So identifying these leaky systems is really important. This is work that others have done as well and seen the same thing. So Brian Cheeseborough in Oregon has led a lot of this work and is, I think, publishing this now. So identifying this leak, was not possible without having this data. And now that we have it, we're working to decommission or abandon that central supply so that we can use portable tanks that can close between uses and really eliminate all of that waste and leak that we are seeing with our central system.
Wow, that's an amazing story. And, just to add a little bit more to it, I think it's a credit to the group at Seattle Children's. It's the clinicians that drove this. They modified their practice to the extent they essentially abandoned use of nitrous oxide, which has been established for 85, 90, 100 years, and they're down to less than a fraction of a percent now. And because of that, and you've identified this leak, you're now in a position to actually decommission the nitrous supply, and we won't have this background leak which contributes thousands of tons, literally thousands of tons of CO2 equivalent. So amazing story. Let's just see how that will impact. So even before we get rid of the automatically leaking nitrous oxide, tell us about the financial impacts.
Right. Yeah. So the nitrous oxide, we're paying for all that nitrous that's just leaking out of those tanks. So we're going to end up saving money from that once we, are able to fully decommission that system. So that's not even in this chart. That's separate from this chart. So this chart is our main hospital's volatile anesthetic costs. So we have the three main volatile anesthetics that are used: sevoflurane, isoflurane, and desflurane. They're expensive. Desflurane is the most expensive one. Even though we weren't using it that much, we still spent almost $50,000 a year on it before this work started. And then when we stopped using it routinely, the last actually couple of years, 2021 and 22 on here, were just because we had a contract to continue purchasing it. We weren't really even, intending to use it. And that's part of the reason that we removed it from formulary, is so that we could just stop purchasing that desflurane that we didn't even want anymore. So that's the story with desflurane, cost savings of almost $50,000 a year. Sevoflurane, where we're still using it a lot for many of our patients, but remember, we're using it more efficiently now. We used to spend $200,000 a year on it. Now we're down to about 75,000 a year, which is a really impressive decrease, and that's even taking into account that our volumes increased in the last year. So we have a slight increase in our cost from 2022 to 23. That's because we did more cases. So our cost per case actually continued to go down. We're seeing, our total emissions from our main operating rooms, our ambulatory surgery center, GI suite, and interventional radiology suite all coming down. So we have this really, really dramatic decrease in our emissions as well as our costs.
Great. I think so. The message to the C-suite is you can do both. You can have sustainability and you can have good financial stewardship and you can do more with less, which is kind of the pressure that we're all being faced with.
Yeah,
so
absolutely.
a win-win-win. Okay, so as we wrap up, I want to give you the opportunity to tell us a little bit more about Project Spruce. What does it stand for? How do we get involved? And does it take... You took 5 years to develop the playbook, and how fast are you seeing results now?
Yeah. So Project Spruce, I talked about it a little bit already, but I don't think I explained what it stands for. Saving our planet by reducing carbon emissions. You have to have a good acronym and a good logo. So this is it's a quality improvement project. And we have seen, that sustainable healthcare delivery is quality healthcare delivery. This is all part of quality improvement. It's not separate from it. This is all tied together. And as I mentioned, we had an opportunity to present what we had been doing at Seattle Children's at some conferences with other groups, and getting that interest from people through this special interest group in sustainability and other organizations. We've scaled up now, and we have multiple hospitals that are doing this work. So, I mentioned some of the folks doing this at other hospitals. This is one of them. They had baseline emissions of 0.2. Within, their start of their improvement phase, had a reduction down to 0.15. And now with the data feedback and more continuous improvement work, they're down to 0.11. So almost a 50% reduction really rapidly. And Dan, I think you wanted to mention something about the pivot slide here.
Yeah. And again, it's now we've trailblazed the way. You don't have to do things sequentially. You did everything. These hospitals are doing everything at once, or a much more compressed timeline. So you can see individuals improve dramatically in 3 or 4 weeks. In this case, 10 weeks, they've halved. Our latest hospital, one of our latest hospitals joined the consortium. We saw a 50% reduction in 30 days. I mean, again, beyond my wildest dreams. I didn't think a hospital system could move that fast, but here you go. So, and I know, Chad, you're talking to this hospital system already with their C-suite saying, hey, come and join. You've already done this work. You might as well, if you do, you've got one big piece of the puzzle. If you do the other 2 pieces, you get this, you can get the fast track you to the certification. So it's wonderful what we're seeing here. Thank you, Liz, and thank you, Chad, for partnering with us for doing that. And we'll just leave you with another QR code. If you want to find out more information about Project Spruce, this will take you to a form, and there's also a link at the end of it that will get you to the website for more information, but someone will reach out to you and give you more information. Well, this has been a great session. I know we're coming up to the hour, and I just want to kind of wrap up with, say thank you, and maybe pass it back to Chad and say, if you want to get, do you have any kind of parting words of wisdom? If people want to get more involved, more information about the certification, how do they go about it?
Yeah, thank you, Dan, and really appreciate the opportunity to join the webinar today. We do have a QR code if you need more information on our certification program, embedded in the slide here on that resource center page. If you're interested in learning more, just taking your own journey and learning through organizations like Liz's organization and learning about their journey, take a look at our resource center. There's a lot of strategies and resources out there for organizations to assist them. But really appreciate the opportunity, and I love to see the work that goes on in organizations, and Liz showcasing this and being really a trailblazer in this space. So really applaud you for your work.
Well, thank you so much, Jed. I really appreciate that. And I also am very grateful to have the chance to share what we've been doing with Project Spruce with all of you.
Well, thank you, Liz. Thank you, Chad. Thank you, audience, for tuning in today and hearing about the Joint Commission's work in this space, Dr. Liz Hansen's work in this space, and over a dozen now hospitals across the world. We have a hospital in Canada that's joined Project Spruce. We have a hospital in Australia that's joined. So stay tuned for that. And it's an open enrollment for any hospital that wants to be involved. So we're hoping that this will generate some interest. Please click on the QR code, give us your contact details, and someone will reach out to you if you want to find out some more, and maybe we can join forces and go save the planet together. So thank you, everybody. Thank you for your time. Thank you, Beckers.